Dear colleagues, we are all used to perform compression in indications like chronic venous disease, thromboembolic diseases of the extremities, post-thrombotic syndrome, venous malformations, lymphedema and lipedema to improve vascular function and to prevent or treat signs and symptoms. However, there are more modes of action of compression devices. There is anti-inflammation, there is anti-tissue damage, there is pain reduction, edema reduction in non-vascular edema, there are effects on proprioception and effects on recovery after sports. In consequence, there are indications beyond venolymphatic diseases. One indication is edema reduction and prevention in non-vascular edema. Edema in obese patients is a frequent finding. In the recent Lymprint study, 39% of patients with severe obesity had advanced leg edema, which can be controlled by compression. Prolonged sitting and standing are other reasons for leg edema and fatigue. Latimer could show that marks for tissue damage increased during standing, which can be prevented by compression. Kramer et al. Reported the influence of compression hosiery on physiological response to standing fatigue in women. Edema may also occur in diabetic patients. Gastaldi et al. Could demonstrate similar microcirculatory changes in diabetic patients as in chronic venous disease. Compression can improve the edema safely if contraindications are respected. Drug-induced edema may occur as side effects in a long list of drugs, as recently shown by Lajeau. If an easy change in the drug treatment is not possible, low-pressure compression stockings may be useful. Post-traumatic edema may occur due to tissue damage and inflammation. Klein et al. Could show that lymphatic treatment, including compression, is able to improve edema in these patients. The same is true for edema after reperfusion of arterial occlusions. Nichols et al. Could recently show that compression is able to reduce post-interventional edema. Compression is only contraindicated if the ankle pressure is below 60 millimeters Hg. Compression has anti-inflammatory activities. Therefore, compression can be used to improve inflammation in inflammatory skin diseases like non-vascular ulcers, vasculitis, cellulitis, erythema nodosum, and eczema. Beitler et al. Could demonstrate the anti-inflammatory effects in venous ulcer patients. In 30 patients with venous leg ulcers, compression bandaging was performed for 4 weeks. Biopsies from healthy and ulcerated tissue before and after therapy demonstrated that compression significantly reduced the elevated pro-inflammatory cytokine levels. In clinical practice, compression is used in addition to antibiotic and anti-inflammatory drug treatment in cellulitis and leukocytoclastic vasculitis. However, no RCTs are available. In a recent international consensus document on risks and contraindications of compression treatment, the following was recommended. We suggest additional compression in purpura due to leukocytoclastic vasculitis and in leg erysipelas or cellulitis to reduce inflammation, pain, and edema. In infectious inflammation, we suggest compression only in combination with antibacterial treatment. Valentina Dini published her personal experience with compression in 31 patients with leukocytoclastic vasculitis and commented, "In our experience, compression therapy by short stretch bandages in vasculitis ulcers with or without venous insufficiency was very useful in order to improve the healing time, relieve the burning sensation and pain due to the reduction of inflammation of blood vessels." In our opinion, the compression therapy can be used in the inflammatory phase of vasculitis with or without leg ulcers to reduce the administration of systemic steroids. Alberto Macchio published his experience with compression in erysipelas and showed that a bandage applied to the lower leg with erysipelas can reverse the clinical sign of redness, which starts proximally where no bandage was applied. In a prospective randomized study, Eberhard Rabe could show that compression therapy is able to prevent recurrent cellulitis of the leg in edema patients. Erythema nodosum is a septal panniculitis that is characterized clinically by tender, erythematous subcutaneous nodules that are predominantly localized on the pretibial lower legs. Compression is a standard treatment in this condition, although no RCT is available. Gollish published 2 case reports showing the beneficial effect of compression in erythema nodosum. Further indications of compression treatment are reduction of nausea and vomiting in early pregnancy. This could be demonstrated in a crossover study by Erika Mendoza. Improvement of impaired proprioception in patients with neurological diseases and in sports are another indication. Guy et al. Published a meta-analysis on the influence of compression garments on proprioception. Improvement of post-exercise recovery is another indication. Riordan et al. Could show that compression-induced improvements in post-exercise recovery are associated with enhanced blood flow and are not due to the placebo effect. In summary, compression has a wide range of indications, even beyond venous and lymphatic diseases. Thank you very much for listening. It was a pleasure having you here.